Good morning, everyone, and thank you for joining us for our Research in Progress webinar. My name is Carrington Lott, and I'm the Program Manager at Systems for Action, which is a national research program office of the Robert Wood Johnson Foundation that is located at the Colorado School of Public Health. If you're not familiar with Systems for Action, we fund research projects across the nation that focus on innovative ways to align the public health, social sector, and the medical sector. And today we're going to be hearing from one of our teams at Benefits Data Trust and UPMC, who I believe this is their third time presenting at our Research in Progress webinar. So they're going to have some exciting updates for you all. And they will be presenting on their project, Connecting Vulnerable Seniors to Nutrition Assistance Through a Managed Care Plan. Advance the slide. So after I do a little bit of housekeeping, I'll hand it over to the team so that they can do their presentation, and then we'll reserve about 10 to 15 minutes at the end of the presentation for questions and answers. So if any questions come up along the way during their presentation, please feel free to click on the Q&A box at the bottom of your Zoom screen and enter in your question, and we'll make sure that we address that at the end of today's session. So I'll give a little introduction to each one of our presenters. We have Lisa Dillman, who is Benefits Data Trust's first ever Senior Research Manager. And since joining BDT, Lisa has led the development of BDT's overall research agenda in coordination with staff across the organization, as well as external collaborators. We also have Suzanne Kinsky, who is the Director of Research Translation and Capacity Building at UPMC's Center for High Value Healthcare, and has nearly 20 years of experience implementing and evaluating both community and clinically based healthcare initiatives. And lastly, we have Qingfeng, who is the Program Administrator for the Data Analytics at UPMC Center for High Value Healthcare. With that, I'm going to go ahead and hand it over to the team so that they can dive into their project a little bit more. I'll stop sharing my screen now, Suzanne, and you can share yours.
Fantastic. Let's make sure that, can folks see the slide that says overview of community health choices? Fantastic. Okay, so Carrington was correct. This is the third time that we have shared about our project, but it's the first time that we've actually had somewhat of data to share, so we're excited. Of course, it's interim data. I'm not going to go into as much detail as we have in the past, because for some of you that might be a repeat, but if you would like to ask more questions about it, we're happy to answer those. Just a disclosure that I am not an expert in the minute nuances of CHC, of which there are many, but I can definitely do my best to answer questions and find out that information for you in the future. But so Community Health Choices is a Medicaid product for Pennsylvania. Prior to 2018, long-term services and supports for individuals eligible for Medicaid was operated by the state on a fee-for-service basis. And then in 2018, like many states are doing, Pennsylvania started to transition to managed care for Medicaid long-term services and supports. And so UPMC, which is a regional managed care organization, is one of 3 state entities that provide this insurance product. So our Medicaid product is called Health Choices, and our long-term services and supports product is called Community Health Choices, or CHC for short, which is how I will be referring to this for the remainder of the presentation. So what is managed long-term services and supports? It's coverage for people who are living in nursing facilities, who are on home and community-based service waivers. These would be people with Medicaid, without Medicare. They could be custodial nursing home residents, so this product provides benefits for them. And it could also be folks who are living in the community who are either older and or people with disabilities who are clinically eligible for nursing home services, but in order to stay in the community need various supports to stay living in their home or within the community. So if you're 21 or older and you have both Medicare and Medicaid benefits, or you're receiving long-term services and supports through Medicaid because you need help with everyday personal tasks, you're covered by Community Health Choices, or CHC. So we currently have about 125,000 people enrolled in our CHC product. And then just a little bit about the UPMC Center for High Value Healthcare, which is the entity that I'm affiliated with. We were established in 2011 as a nonprofit research entity housed within the UPMC Insurance Services Division. So within this broad corporate entity that is all of the insurance products that we offer, we have an independent research center that is doing research and evaluation related to models of care. And it can be everything from tiny pilots that we offer in terms of services we provide our members to large PCORI-funded pragmatic clinical trials that we're doing with vulnerable populations. And so this partnership with BDT is an example of some of the research collaboration that we're able to do because of our position within the health plan.
So at Benefits Data Trust, or BDT, we focus on connecting people to public benefits. And this slide really shows our primary service delivery model. So first, we work with partners' data to identify who is likely eligible but not receiving public benefits. And then we conduct outreach through largely letters or text messages to individuals, letting them know of their eligibility and directing them to call our contact center. And our staff in the contact center then screens people for benefits and assists in the application process. And ultimately, through our data partnerships, we're able to track people through the process to better understand the outcomes of our outreach efforts and then ultimately use that information to improve those outreach efforts. So next slide, Suzanne. Thanks. So in doing this work, BDT works with a lot of different partners. These include government agencies, local community-based organizations, philanthropic organizations, and most recently, we've been working with healthcare organizations such as Medicaid managed care plans, like UPMC, to directly help their members access the benefits for which they're eligible. And these types of partnerships really make a lot of sense because public benefits help households with many different domains of the social determinants of health, including food, healthcare, heating and energy assistance, housing, etc. And there are large participation gaps in many of these programs. Many people who should be enrolled, especially those who are receiving Medicaid, are unfortunately not enrolled in these essential services. So we began talking with UPMC about doing this work together to help their dual eligible individuals access benefits in around 2016. And we leveraged our service delivery model that I just described to help conduct targeted outreach and help with benefits application assistance starting in 2019. Back to you, Suzanne.
Perfect. So BDT approached us, gosh, probably in 2018. So CHC partnered with BDT, and the plan was we're going to give you a list of all of our members, and BDT is going to do outreach to them and try to get them enrolled in public benefits. We were specifically interested in SNAP benefits or food stamps. And so when we approached Robert Wood Johnson with the idea to build a more rigorous research design around this, we opted to do a waitlist design. So a situation like this made the waitlist design really attractive because we were anticipating tens of thousands of individuals who were enrolling in CHC who we would provide to BDT that they would have to do outreach to. And it's not feasible to do tens of thousands of outreach letters all at once. So we knew that there would be some sort of wait list just by necessity as part of normal practice. And so what we decided to do was to institute a randomization scheme to a waitlist design. So it's a 2-to-1 randomization. So 2/3 of eligible members were randomized to receive immediate outreach during the sort of active intervention phase. And then 1/3 were held back to do delayed outreach, and they will form our control group. So the primary goal or the question of our evaluation is really, what does SNAP enrollment do to healthcare outcomes? So it's really about the efficacy of SNAP enrollment. It's of particular interest to us as an insurer because we are really focused on keeping people in the community, so keeping them as healthy as possible in a place where they want to be and we want them to be. Or for folks who came to us in a nursing facility, transitioning them back into the community. And we've definitely transitioned several hundred people from a nursing facility level of care back into the community. And supports like this is how that can happen. And so there's a public health question aspect of this, there's a business aspect of this, there's a patient-centered aspect of all of this. And so we're really looking at like, what does SNAP do? So our primary dependent variable that we're looking at is hospital utilization within 12 months after enrollment in SNAP benefits. And we also identified some other secondary outcomes that include quality of care and other utilization and cost outcomes. So at this point, this is what our research data flow is. And we're going to revisit this slide because we have a lot to talk about. But basically, what happens is we have a list of our CHC members and we send that to BDT. BDT has a partnership with the Pennsylvania Department of Human Services, who is what manages SNAP benefits. They share that list with the state, and the state removes people who are already on SNAP benefits because obviously we're not going to try to re-enroll people. So then once BDT gets a clean list of people who are not on SNAP, but because they're receiving Medicaid benefits, they should be eligible. Then they performed the 2-to-1 randomization, right? And so then we have the 2 cohorts that we talked about. Here is sort of the conundrum that we'll address later, but it's how to figure out who is in the intervention and control group. So we know who BDT sent outreach letters to. We also have a partnership with the Pennsylvania Department of Human Services. So we know all of our CHC membership and what their SNAP enrollment status is. And so from there, we're going to extrapolate who the control cohort is. So one of our goals when we set this up and we said, yes, we'll present in September, was we could present more of an outcomes analysis to you, but due to some of the complications with how this data flow happens, we're still sort of working through the nuance of that. But what we do know, because we have current data from the Pennsylvania Department of Human Services that goes from January 2018 to June 2020, is we know a partial list of CHC members that received outreach from CHC and either did or did not enroll in SNAP after that initial outreach. And so what we'd like to present to you today is just a basic descriptive analysis of after outreach, who wound up enrolling in SNAP and who didn't. So the caveat is, one, the data is incomplete. There, I think, are a lot more people that wound up getting SNAP enrollment after June 2020, and we just don't know it yet. And we need updated data. And also the who got SNAP after outreach and who didn't get SNAP after outreach, those are not our 2 comparison groups. This is really a within group comparison of the intervention group. So with that, we're happy to sort of present some basic things. I'll turn it over to my colleague Qingfeng to present the first couple of slides.
Thanks, Suzanne. And BDT conduct outreach to over 11,000 CHC members in 2019, 2020. And we linked the outreach list with the DHS SNAP benefit data to see members enrolled in SNAP or not after outreach. And we found out that about over 2,400 members enrolled in SNAP after outreach. That's about 22% of outreach members. And that's still like a 78% that did not enroll in SNAP benefit. And then we group those members into 7 age bucket by a decade. And then we perform chi-square tests to test the distribution for the member enrolled in SNAP versus did not enroll in SNAP. And the test is significant. And if we look at the left side of the graph, the blue bar is higher than orange bar. I mean, younger CHC member more likely to enroll in SNAP after outreach than the older member. Next slide. And we also take a look at distribution for gender. And for those enrolled in SNAP, 66% are women. And for those did not enroll in SNAP, and 60% are women. So women are more likely than men to enroll SNAP after outreach. Next slide. And we also take a look at the race and ethnicity distribution. The left side of the graph shows the race distribution. The right side shows ethnicity. And let's look at the left side first. We see African American, Asian, Pacific Islander are more likely enrolled in SNAP after outreach compared to white. And then it shows the same pattern for ethnicity also. Hispanic or Latino are more likely enrolled in the SNAP than the non-Hispanic individuals. Back to you, Suzanne.
Thank you. And then a couple breakdowns by other clinical or categorical factors that are important to us is one, this horrible acronym called NFCE, Nursing Facility Clinical Eligibility. So again, this is a category of Medicaid benefits based on your health status and what level of support that you need. And so there are technically 3 levels of this category. One is your nursing facility ineligible, which means that your health status is such that you don't need any help in living in the community. You don't need help with ADLs or IADLs. And so the Medicaid part of your long-term services and supports is actually a pretty minimal benefit. And NFI individuals make up most of our CHC members. Then you have folks who are receiving home and community-based services in the community. So they are clinically eligible for nursing facility levels of care. So assistance with ADLs, IADLs, you know, that could be personal attendant services. It could be ramps in the home. There's a variety of different services. But the HCBS folks are living in the community. And then there's people in nursing facilities. So people who are in a custodial arrangement. So they are not represented here because they're excluded from our target population. They're not eligible for SNAP anyway. And so for our study and for this analysis, we're obviously only focusing on folks who are either HCBS or NFI. And so here you see pretty similar bars in terms of who enrolled in SNAP across the home and community-based services and the nursing facility ineligible groups. And in fact, this was not statistically significant. So there really was no difference in terms of SNAP enrollment across these groups. And then we also looked at a measure of comorbidity that I'm sure a lot of you are familiar with, called the Charlson Comorbidity Index, which is a measure of chronic disease burden. It's a weighted measure based on presence of certain comorbidities. And then we also used age-adjusted Charlson Comorbidity Index, which is what is represented here. And I apologize for the formatting got a little off, but basically the age-adjusted CCI adds an additional point for each decade over 40. And so for people who enrolled in SNAP, their mean age-adjusted CCI was 3.02, and then for non-SNAP, it was 3.22. This was statistically significant, but we've talked about it among the team, and I don't know that there's really a clinical difference between a 0.2 level in terms of CCI. It would be very different if there was a several point difference, and that happens in other analyses where we have folks who are relatively healthy versus folks with a high chronic disease burden. But here, even though the mean age-adjusted CCI was different, it seems pretty similar to our eyes. And then finally, some intel about geography. And so this is important. Let's see if we have, whoops. So just some background about this. Pennsylvania rolled out community health choices in 3 phases. So in 2018, these 2 regions, I don't know if you can see my cursor, but Allegheny and Southwest. So this represents sort of the southwest corner, which is Pittsburgh. In 2019, it moved to Philadelphia and Southeast, so Philly, a very small but highly populated geographic region. And then in 2020, it went to the rest of the state, which is sort of by Medicaid grouped into the Lehigh Capital Region, which is Harrisburg, where our state capital is, and then northeast and northwest corners of the state. So the folks in Allegheny and Southwest have had managed CHC for the longest, and then the folks on the right, who are Lehigh Capital, Northeast, Northwest, have had CHC the least amount of time. They've only had it for about a year and 10 months. So if you look at who by geography was more likely to enroll in SNAP, what stood out to us pretty quickly is that the two urban regions, which is Allegheny, which is essentially Pittsburgh, the city of Pittsburgh, and then the city of Philadelphia, were the ones where we did see that there was a higher rate of enrollment in SNAP relative to the other regions. So here I am revisiting our lovely research data flow graph, and we can sort of share our pain with the rest of this group, which we have talked about before. So the PA Department of Human Services has been great. They supported our application from the very beginning. But when you get down to the nitty gritty of like, what does that data use agreement actually look like? It gets very complicated. So BDT has its own relationship with the PA Department of Human Services, where they have an agreement to share names and data back and forth. It became apparent very quickly that UPMC needed to have its own agreement with DHS. And we, in fact, have that, obviously, since we're getting data, but that was honestly years. Thankfully, I wasn't involved in that, but it caused a lot of pain and grief to get that. And really, I think this has been shared with prior webinars, but the way that we argued this to Pennsylvania was that this is about helping the state understand how to better care for Medicaid members. And to understand what services are necessary. And I think everyone knows that there's been a stronger focus and emphasis on social determinants of health and how to meaningfully integrate that into healthcare. And we see this as answering a really important question and answering one that to date doesn't exist in the literature yet. So where we are now is in this place that we don't love, but we know it's possible, which is because BDT cannot share with us data on the control group, which I'm sure we can explain better if we need to. We have to get a list of all of our CHC members, pull out the people who do not have SNAP, and then compare it to the group that got outreach versus the group that we sent it to them, and sort of by process of elimination, define the control group. But then even that is challenging, it just in the sense that the state and BDT works on a household level, and as a health insurer, we're not really used to thinking of our members as a household level. And so there's this issue of deduplication that's even sort of just two people speaking two entities speaking slightly different languages, trying to get together and confirm and understand that we're all on the same page in terms of how things are defined. And then I will turn it over to Lisa to provide some policy insights and probably dig in a little bit more to some of our challenges.
Sure. So while we're still in the process, as Suzanne let you all know, of conducting analysis related to the outcomes of interest in this study, even in just these simple descriptives that we presented, there are some sort of policy insights and considerations that we wanted to highlight. Overall, the differences that we noted in who enrolled in SNAP after receiving outreach tell us that more women, African Americans, Asian Pacific Islanders, people identifying as Hispanic, and people in urban areas enrolled in SNAP after outreach. And these findings are largely consistent with what we observe in national SNAP participation rates. So what this does is raises some questions around if there's something intrinsic to these higher enrolling groups that makes them either more likely to successfully navigate the process, or more motivated and or less hesitant to do so, Or are they better accommodated by their local DHS office? So as an example, might people in urban areas have easier and more convenient access to services? There could be more language interpreters in urban settings, and maybe even less stigma as compared to rural settings where it's harder to sort of remain anonymous. And even when we didn't see differences in the groups enrolling in SNAP, there are still interesting things to note. When we see no difference in the enrollment rates for those requiring more intensive Medicaid services, that could indicate that the physical and/or cognitive limitations that these individuals experience might not impede successful navigation of the SNAP enrollment process, or it could point to them possibly having others assist them throughout this process. So there are many additional research questions that we could pursue along these lines in the future. And then finally, what is a presentation without a mention of COVID in 2021? So we just wanted to remind everybody of the ways in which COVID particularly impacted this project. So policy changes were introduced to help states kind of strike this balance of meeting the need of increased demand, yet still maintaining necessary safety protocols in helping people get signed up for benefits. And what this meant was that there was more application flexibility, which might have led to more people enrolling than otherwise would have. Also, prior to COVID, the amount of SNAP benefit a household received was variable based on income and resources for that household. But during COVID, everyone received the maximum benefit. And so what this means here is there might be a case where seniors living alone in a household could have received around $16 a month prior to the pandemic and upwards of $200 a month once the policy was changed. So all of this, of course, will influence our analysis and ultimately our findings and the conclusions we draw from them. So stay tuned. We'll be looking forward to updating you when we have more data to talk about.
So I think at this point, we're going to open it up to questions. Should I continue sharing my screen, Carrington? Or...
Yeah, I think that's fine because I have the same slide on my screen that I would share. So
okay.
I think that'll be great. Thank you, team, for presenting and talking about your project and for sharing those analysis with us. I'm going to take advantage of being the moderator and ask the first question. Just generally, can you tell us what the next steps are in your project?
Yeah, absolutely. So right now, the UPMC and BDT are working together to test our assumptions about how we can, by process of elimination, define that control group. And this has always been our intent from the very beginning to not only do that as just a quality check, but then also do interim analyses, again, just to make sure that like we understand the structure of the data, right? I think that's just sort of a research best practice. And so there's a lot of emails flying back and forth this month between us trying to disentangle these things. So our general timeline is active outreach so sort of the end of the intervention period ended approximately October of last year. So we are getting close to the end of what we would consider the last people's 12-month observation period. So we need to allow a little bit of time for claims run out, which is generally 2 to 3 months. So early 2022 is when we will really get down to brass tacks in terms of doing an outcomes analysis. Interestingly, we had always proposed doing propensity methods to test the impact of SNAP enrollment between intervention and control groups, but we've had some really interesting discussions with colleagues of ours at the University of Pittsburgh who are helping on other projects related to community health choices, who have suggested an instrumental variable approach. And so we're actually sort of running down that possibility as an even stronger research design. So if folks have thoughts about instrumental variables or papers to share, like please send them. We would be happy to read them, as Lisa and I are just sort of feel like we're getting used to that methodology.
Great, thank you. Yeah, and as a reminder, this team will present again at some point next year. So we'll send an email reminder to everyone that's here today joining us so that you can join next year to hear about these exciting updates. So I'm going to move on to some questions that have come into our Q&A box, and that we have plenty of time left. So if any questions come up, please make sure that you're entering those into the Q&A box at the bottom of your Zoom screen. There is one that Ashley Humaney has addressed already, but I did want to bring it up just so that we could talk about it out loud. So James Stowe was asking about SNAP as a program and if there's any scientific basis for how this program is at addressing social needs and just overall household nutrition. So Ashley, I don't know if you want to jump in and talk about it since your response was very thoughtful, or if the rest of the team would like to address it, but I thought it would be worth discussing.
Yeah, I'm happy to start, and just wanted to begin my answer with the fact that we are always looking to build the body of evidence around the impact of public benefits such as SNAP on health, on long-term economic mobility, on nutrition specifically. So this is the reason for this project existing, is to continue to really hone in on answers specifically among certain populations. Don't necessarily want to get into all of the research and details around the impact of SNAP, but so happy to have an offline conversation. And I can point anyone to additional research and resources. There's a lot of research showing that receiving SNAP as a child reduces the occurrence of heart disease and diabetes in adulthood. Every 1 billion in SNAP benefits generates, I think, like 18,000 full-time jobs, helps women achieve self-sufficiency through increased educational attainment. So lot of research, and even research specific to healthcare costs and outcomes related to SNAP. So we're always looking to create, to build the data, to build the case. And it's kind of definitely part of our work here at BDT and part of Lisa's work as well as a researcher. So would love to dive into this, and James, please feel free to follow up with us afterwards.
And Ashley, it may be worth sharing the links that you shared with James in the chat so everyone else can see those as well.
Will do.
Thank you. So we're going to move on to a question from Pamela now. She has a question about rurality. So are all areas outside of Pittsburgh and Philly classified as rural by federal definition or the Pennsylvania definition of rural?
Yeah, that's a great question. I think, I'm not sure by the measure of the geographic regions that we have here. So these are sort of how the state defines geographic regions. I would say Allegheny and Philly, because they are housing the two largest cities in Pennsylvania and are, basically the size of a county, are urban. Outside of that, I think the definition of urban versus rural would probably be smaller than the larger region. So we have cities like Altoona and Allentown and Erie that, based on different federal definitions, would be more urban or more rural. But I mean, in terms of, the joke is that, that it's if Pittsburgh on one end and Philly on the other, and like some rural state in between, right? But like it does really very much feel like the state is anchored on either end by these two large metropolitan areas and then sort of pseudo metropolitan areas scattered throughout. But there's a high proportion of rurality throughout Pennsylvania. I don't know if Lisa,
Yeah, well, just to comment on that, on the findings on that slide, the interesting sort of place that would be like maybe on this border between urban and rural is the capital area, so where Harrisburg is. And if we looked at the trends, like we saw the urban areas, Allegheny and Philadelphia, we saw more enrollment in SNAP and then less enrollment in the rural areas. And that sort of borderline area, we didn't see a difference between. So it was kind of an interesting continuum of the observations that we made there.
Thank you. We have another question that came in from Pamela, specifically to Lisa. Could you repeat the senior max household SNAP benefit per month during COVID-19?
Oh, I was not super specific about it. It's because it still varies by like state and household size. But it's very possible that seniors who were receiving as little as $16 a month might have upwards of 200. And I think we saw the highest amount at like 234 when we were poking around in the data yesterday. Suzanne, does that sound?
Yeah, we looked at, I think it's even higher than that for the max. I think that might have been the 75th percentile. On average, of the months that individuals in our data set got SNAP, their monthly benefit was $105. But keep in mind that our data includes people on SNAP both before and after COVID, and COVID rules and policies definitely increased that. So it would be worth looking into sort of the average amount pre-COVID and post-COVID.
So Susan asks, do you see any enrollment program is more effective than the other? Since in-person outreach is becoming difficult, can you share some of the outreach methods that you're doing?
Yeah, and I don't know, Ashley, if you want to jump in on this, but we're doing a lot of different outreach and for a lot of different programs, and you know, we're trying text messaging in some instances. Largely, you know, beyond SNAP, the benefit that actually changed the most in terms of how people access it is WIC, and WIC used to require an in-person visit and no longer does. So that has really changed, but our outreach strategies have kind of remained the same. We're really reliant on contacting people at the individual level. And so letters and text messages are really our primary modes. Ashley, did you want to add anything to that?
No, I think that's a great summary. In some cases, we accept direct referrals, but our outreach and engagement strategies, yeah, all depend on kind of the smart use of data and the smart use of different engagement methodologies. So you summarize it well, Lisa.
Okay, so we're moving on to the last question that we have right now, unless any others come in. So this is from Patrick, who has a question about the instrumental variable analysis that you're considering. What can you be more specific about what instrument you are considering?
Yeah, absolutely. So because we randomized individuals to immediate or delayed outreach, that is the instrument, that it's sort of an arbitrary selection, right? And so yeah, sorry, I'm having too many thoughts going through my head. So yeah, so the fact that folks were randomized to receive outreach or not is the variable. And so then I believe what we're doing is currently doing some of the assumption testing to make sure that that instrument satisfies all of the requirements in terms of how it's associated with both the treatment and the outcome.
Thank you. Okay, so that brings us to the end of our questions. If no one has any other questions right now, I think I'm going to offer up maybe to share the team's emails and our follow-up email that we will send that will include the recording inside. So if any other questions come up, you can feel free to reach out to the researchers, or if you have any input or anything like that on their upcoming analysis, you can definitely reach out to them. Suzanne, can I ask you to advance to the next slide? And we'll start just closing us out here. So we do offer certificates of completion. So at the end of this research and progress webinar, when we close out, you will be prompted to fill out a little survey. And at the end of that, you can indicate if you'd like a certificate. And if you say yes, we'll make sure to get that to you in a timely manner. And then next slide, please. And then this is a bi-weekly series. So we do have another research and progress webinar coming up on October 13th on addressing the health and social needs of justice-involved youth. And that it will be from our team at Texas A&M. And then October 27th, we'll have transit and treatment, the effectiveness of transit system to improve substance abuse and mental health in Connecticut, which is our team at the University of Connecticut. So if you would like to join for those, the link will be included in the PDF that we will send in our email follow-up. Next slide, please. And as always, we are the National Program Office of the Robert Wood Johnson Foundation. So we definitely want to acknowledge that and thank them for their support. And with that, I think we will end a couple minutes early here and give you back 20 minutes of your day. But I want to thank our team for presenting today, and thank you all of you for joining. I hope everyone has a wonderful rest of their day.
Thanks, everyone.